Welcome, USMLEers! My name is Zuk Azalishvili and I'm the founder of USMLE. USMLE is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your STEP exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at USMLE. Now, let's start rolling. Today we start the respiratory series for USMLE Step 1. And this particular episode will be episode 1 for the respiratory series. And it will be about the respiratory embryology. However, let me tell you that I will make clinical correlations which might be out of the realm of the respiratory embryology, but the title and the focus of today's episode is certainly embryology. Let's start. The first topic from the respiratory embryology is, not surprisingly, the development of the lung. And we should remind ourselves that lung, specifically the respiratory epithelium, is derived from the endoderm. And what happens is that the foregut creates this diverticulum, which is called the lung bud, and we then have 5 stages of lung development. We should know the order of these 5 stages, and we should know what clinical correlations are associated with each of these lung development stages. So let's start. The first stage of respiratory embryology is embryonic period, which occurs from 4 to 7 weeks gestation. And during the embryonic period of lung development, as we already mentioned, the foregut forms the diverticulum called lung bud, and lung bud will give us trachea. Trachea will finally bud into the bronchial buds. Then we will receive the mainstem bronchi, aka primary bronchi. Primary bronchi will then develop into secondary or lobar bronchi, and then lobar bronchi will have tertiary or segmental bronchi. As you can see, even in the embryonic phase of lung development, we already have everything up until the tertiary or segmental bronchi. And very important thing that might happen at this stage is that if we have a defect at the embryonic phase of lung development, then this might lead to a defect called Tracheoesophageal Fistula. Do you remember what Tracheoesophageal Fistula is? I hope you're saying yes, and let me also remind this. Tracheoesophageal Fistula is a fistula or connection tube between trachea and esophagus. It has many different types, and discussion of tracheoesophageal fistula types is out of the realm of our today's discussion, but the idea is that trachea and esophagus are normally separated by thin wall from each other. And this wall is created at the embryonic stage of lung development. So if embryonic stage does not go on as it should have gone, then we will receive tracheoesophageal fistula. After the embryonic stage of lung development, then we have pseudoglandular period. And pseudoglandular period lasts from 5 to 17 weeks of gestation. You can see that there is an overlap between embryonic and pseudoglandular period because embryonic period ends at 7 weeks gestation, while pseudoglandular period starts at 5 weeks gestation. And for this overlap and confusion amongst the medical student society, I think that it's not that important for us to know exact weeks of the different stages of the lung development. We should know the trimesters, and I will list them for you at the end of this topic, and we should know the clinical correlations. Let's continue with the pseudoglandular period. In the pseudoglandular period, we form the terminal bronchioles. If you remember, the embryonic period culminated in the development of the tertiary bronchi, and in the adult lung, tertiary bronchi is followed by the bronchioles, and then bronchioles are followed by the terminal bronchioles. Therefore, it means that development of bronchioles and the terminal bronchioles happens at the pseudoglandular stage. However, respiration is certainly impossible at the pseudoglandular stage because we don't have alveoli at this phase, and therefore the gas exchange cannot happen if the fetus is born at this period. So if the fetus is born anywhere from 5 to 17 weeks, the result will be spontaneous abortion. After pseudoglandular phase is over, then we move on to the canalicular phase. In the canalicular phase, terminal bronchioles bud into the respiratory bronchioles, and then respiratory bronchioles give us the alveolar ducts. But we don't have the alveoli yet. Canalicular period lasts from 16 to 25 weeks gestation. And similarly, you can see that there is an overlap between pseudoglandular and the canalicular periods of the lung development. And we know that canalicular period is marked by an increase in the airway diameter, and also canalicular period is the period when respiration becomes possible, and it specifically becomes possible at 25 weeks gestation. One important thing as well is that the pneumocytes, or the lung cells, literally, start to develop during the canalicular period, specifically at 20 weeks gestation. Okay, we finished canalicular period by the formation of the alveolar ducts. Now what comes next is saccular period, which lasts from 26 weeks of gestation to the birth of the baby. And saccular period is called saccular because this is when we form the sacs. Alveolar ducts bud into the terminal sacs, but these sacs are just large balloons which are much larger than the adult alveoli. What I'm trying to say is that each terminal sac that we have in the saccular period is not an alveolus at all. They are separated from each other by the primary septae, which are these large septae separating these large balloons. Saccular period does not have that much clinical correlation, so let's move on to the alveolar period of the lung development, which lasts from 36 weeks gestation to 8 years. I would like you to take notice to the fact that alveolar period of the lung development continues even after the birth, and it basically continues until the 8 years of age. An alveolar period, not surprisingly, is called alveolar period because this is when we get adult alveoli. And the process is that the terminal sacs that we received in the saccular period further subdivide into smaller and smaller balloons. And these small balloons are then called alveoli. At birth, we have approximately 20 to 70 million alveoli, while at the end of alveolar period, which is 8 years, we have approximately 400 million alveoli. So this was the process of lung development, and let's summarize it very briefly. We have 5 periods of lung development in the embryo, and there is a famous first state mnemonic which I would like to remind you of. This mnemonic sounds like this: every pulmonologist can see alveoli, and the first letters of each word in this phrase stands for each developmental period for the lung. The first period, as we said, is embryonic period, and the defects at this period result in tracheoesophageal fistula. The next period is the pseudoglandular, and pseudoglandular period is still the period when the fetus cannot breathe. Then we have canalicular period, and this is when the respiration becomes physically possible, and also pneumocytes start to develop. We have secular period then, and finally alveolar period, which is when we receive adult alveoli. This is the general overview of the lung development. Now let's talk about the congenital lung malformations. There are 2 of them which we would like to pay attention to in this episode, but we will focus more on the pulmonary hypoplasia. The second one is bronchogenic cysts. Let's start with pulmonary hypoplasia. Pulmonary hypoplasia is literally what it says. This is when the newborn has hypoplastic or incompletely developed lungs. And the main idea of pulmonary hypoplasia is that it has various causes. We should know all of those causes, but there are certain etiologies which are more high yield than the others, and let's talk about them. One of the very common causes of pulmonary hypoplasia is congenital diaphragmatic hernia. Congenital diaphragmatic hernia is when the abdominal contents, for example, stomach or intestines, or sometimes even the spleen, herniate from the abdominal cavity into the thoracic cavity. And when they occupy the space in the pleural cavity, certainly there is insufficient space for the lung to expand, so the lung stays small. Congenital diaphragmatic hernia is usually present on the left side, and this happens because the left-sided diaphragm is more vulnerable to the herniation due to small size of the spleen. In contrast, the right-sided diaphragm is protected by the liver, which is larger than spleen, and therefore it's very difficult for the abdominal contents to bypass the liver, right? And at the same time, we should note that left-sided congenital diaphragmatic hernias are usually posterolateral, because for some unknown reason it turns out that posterolateral part of the diaphragm is weaker than the other parts of it, and therefore it's easier for the abdominal contents to go through that part specifically. In this type of hernia, I mean the hernia which is in the left posterolateral side of the diaphragm is called Bochdalek hernia. But we also have one rarer type of hernia, which is called Morgogne hernia. Morgogne hernia is when abdominal contents herniate through the foramina of Morgogne, and foramina of Morgogne are anteriorly near the sternum and the lower ribs. Therefore, Morgogne hernia will be anterior hernia, in contrast to the Bochdalek hernia, which is posterolateral hernia. And we already mentioned that the hernia impedes the lung development and expansion, which will result into pulmonary hypoplasia and hypoxia in the newborn. There is one more important cause of pulmonary hypoplasia, and this is bilateral renal agenesis. Bilateral renal agenesis is the condition when the fetus does not have either of his or her two kidneys. In other words, there are no kidneys. And kidneys produce urine, right? And we know that amniotic fluid is mostly baby's urine. The fetus urinates inside the amniotic sac, and that urine fills up the amniotic cavity, and then we call it amniotic fluid. And you can imagine that when the patient, not the patient, but the fetus, has bilateral renal agenesis, then they will have a very small amount of amniotic fluid inside the amniotic sac. There is one more physiologic aspect of amniotic fluid turnover that we need to know before we proceed forward. When the fetus urinates into the amniotic sac, then some of that amniotic fluid is aspirated into the fetal lungs, and that fluid distends the bronchi, bronchioles, and alveoli and keeps the respiratory tract open. In other words, aspirated amniotic fluid is essential for the normal development and expansion of the lung. Therefore, you can imagine that when the infant, not the infant but fetus once again, has bilateral renal agenesis, then the fetus is not able to aspirate enough amniotic fluid, and what we get is just unexpanded lungs, i.e. pulmonary hypoplasia. Okay, this was pulmonary hypoplasia. Now let's move on to bronchogenic cysts and mention it briefly. Bronchogenic cyst is not as high yield as pulmonary hypoplasia, but I still recommend that you know about it at least several points. Bronchogenic cyst is what it says. It's basically the cyst or balloon-like dilatation of the bronchi or terminal bronchioles. Usually it's asymptomatic because it does not cause as significant respiratory impairment as the pulmonary hypoplasia. However, if you take the chest x-ray of a neonate with bronchogenic cysts, then you will see this sharply defined, well-circumscribed densities which might be fluid-filled. But these won't be lung abscesses. Imagine the newborn who has no fever, the newborn's vital signs are normal, and newborn also looks normal, and then you take chest x-ray for some reason and you see those big balloon-like dilatations with fluid. In that case, it's most likely to be bronchogenic cysts rather than the abscess, because the abscesses usually would not be multiple, and plus if this were an abscess, then the newborn would have fever and possibly the vital instability as well. Okay, now let's get back to the bronchogenic cysts. We said already that they are asymptomatic, but idea is that the bacteria can start overgrowing inside the bronchogenic cysts, and that can certainly cause infection. Therefore, most important point about bronchogenic cysts is prognosis or the possible complications of it. And the possible complication is recurrent infections inside the bronchogenic cysts. And this is the bronchogenic cyst. Now we will talk about the several types of respiratory epithelial cells. Specifically, we will talk about 3 types of cells, and the first one is club cells. Club cells are also called Clara cells. In contrast to the majority of respiratory epithelial cells, which are ciliated, club cells are non-ciliated. They are also cuboidal or columnar, but here is the most important point about the club cells. We should know their functions. And the club cells mostly have three functions. First, they degrade toxins. In other words, club cells have immune properties in the respiratory tract. At the same time, they actually secrete component or part of surfactant. We will talk about surfactant in later parts of this episode, but I want you to pay attention to this point. Generally, most of the students think that it's only the type 2 pneumocyte which produces surfactant, but that's not true. Yes, type 2 pneumocyte produces most of the surfactant substance. However, club cell also contributes to the production of surfactant. And the third function of the club cell is that it is a reserve cell, or to say it in other words, it is almost like a stem cell for the type 1 and type 2 pneumocytes. But please don't get me wrong, club cell is certainly not a stem cell. What I'm trying to say is that it can differentiate into the other types of respiratory epithelium to restore it in case of the lung injury. So this was the discussion about the club cells. Now let's move on to the types of pneumocytes, which literally mean the lung cells. We have two different types of pneumocytes, type 1 pneumocytes and type 2. Let's start with type 1 pneumocytes. They occupy the most of the alveolar circumference. Actually, approximately 97% of alveolar surface is taken up by the type 1 pneumocytes. And there is a specific reason behind this. Type 1 pneumocytes are extremely thin. And we know that the alveolus is the place for gas exchange. In order for the gas exchange to happen efficiently, we need a very thin diffusion barrier or diffusion membrane. Therefore, it's better for the alveolus to have type 1 pneumocyte, a super thin cell, as its major component. Then we have type 2 pneumocytes. Let's first talk about the histological differences between type 2 and type 1 pneumocytes, and then we will touch on the physiology and the physiologic implications of the type 2 pneumocytes. Histology-wise, type 2 pneumocytes are cuboidal compared to type 1 pneumocytes, which we already mentioned that are thin. And at the same time, type 2 pneumocytes are clustered. They are clustered at the point where neighboring alveoli meet each other. Now, as for the physiologic role of type 2 pneumocytes, they secrete a substance that we already mentioned during this episode. This substance is called surfactant. Before we talk about surfactant, let's first mention that type 2 pneumocytes contain these microscopic organelles, which are called lamellar bodies. They are seen only through the electron microscopy, and lamellar bodies are simply the aggregates or collection of the surfactant. And the surfactant is constantly released from the lamellar bodies of the type 2 pneumocytes. Now, let's start explaining the concept of surface tension and collapsing pressure, and then we will correlate the concept of surface tension with the concept and the mechanism of the surfactant. Surface tension is the force created on the inner walls of the alveolus, which tries to collapse the alveolus. And the surface tension, this force, collapsing force, is created by the molecular interactions on the inner walls of the alveolus. Then, from the concept of surface tension, we can derive the concept of collapsing pressure, which is actually the same as distending pressure, and I will explain why. Collapsing pressure is the pressure exerted on the air inside the alveolus, which tries to collapse the alveolus. Now, let's compare and contrast surface tension and collapsing pressure. we already said that surface tension is the collapsing force which tries to get the alveolar walls together and collapse the alveolus. However, collapsing pressure is the pressure exerted by the surface tension on the air inside the alveolus. And the formula for the collapsing pressure is 2 times surface tension divided by radius. From this formula, we can say that collapsing pressure is directly proportional to surface tension, while it's indirectly proportional to the radius. And this gives rise to many hypothetical questions on the USMLE Step 1 or in the question banks. They will tell you the different changes in the surface tension or the radius of an individual alveolus, and then they will ask you what will happen to the collapsing pressure. In order to answer such kind of questions, you definitely need to know this formula of collapsing pressure. And, well, it's understandable that collapsing pressure is directly proportional to surface tension. In other words, if we increase surface tension, then collapsing pressure, or the pressure exerted by the surface tension on the air inside the alveolus, will also increase. However, let's talk about the relationship of collapsing pressure and the radius. If we decrease the radius of an individual alveolus, then the collapsing pressure will increase. And this is visible from the formula itself because the radius is in the denominator of the formula for collapsing pressure. However, let's explain the logic behind reducing the radius and increasing the collapsing pressure, or vice versa. When we reduce the radius, and when we keep the surface tension at its constant value, then there is a smaller surface area that the surface tension is distributed on. In other words, on every unit of the alveolar surface area, there is a greater surface tension, there is a greater collapsing force which tries to collapse the whole alveolus. So if there is greater collapsing force working on each unit of alveolar surface area, then definitely small alveolus will be collapsed easier than the large alveolus. So this is the idea behind inverse relationship of collapsing pressure and the radius of the alveolus. If you remember, I told you previously that collapsing pressure is actually the same as distending pressure. Sometimes questions will talk about collapsing pressure, but other times they will mention distending pressure. And please don't get worried and don't panic. Distending pressure is the same thing as collapsing pressure, and let's explain why. In order for the alveolus to stay open, the air inside the alveolus must push on the alveolar walls with the same force that the alveolar walls push on the air, right? And we already said that the force with which the alveolar wall pushes on the air is basically the collapsing pressure. Therefore, the force by which the air pushes on the alveolar walls will be distending pressure, or the pressure needed to keep the alveolus distended. And you can imagine that if collapsing pressure exceeds distending pressure, then alveolus will collapse. So if we have an open alveolus, then collapsing pressure equals to distending pressure. But if alveolus got collapsed, then it means that collapsing pressure exceeded the distending pressure. Okay, now that we have explained the concept of surface tension, collapsing pressure, and distending pressure, let's correlate everything to the concept of the surfactant. Surfactant is actually not a single substance, is basically a mix of this substance called lecithin, which is the same thing as phosphatidylcholine. This is a specific type of phospholipid, and the most abundant type of lecithin in the surfactant mixture is DPPC, or dipalmitoyl phosphatidylcholine. What happens is that the surfactant gets lined on the inner walls of the alveolus, and it reduces the surface tension. It reduces the collapsing force of the alveolar walls. Therefore, we can say that surfactant reduces the alveolar tendency to collapse. And many times the questions will describe this concept in physiologic terms. We will review these terms in the physiology part of the respiratory series, but let's mention them here briefly. Okay? These terms are lung elasticity or elastic recoil and compliance, which are the opposites of each other. Elasticity is the tendency of the lung to just collapse. We are talking about lung elasticity here. And compliance of the lung is distensibility of the lung. So it's how easy the lung can distend and expand with air. We will discuss these two terms in a much greater detail in the respiratory physiology, but for this discussion, I think it's enough to say that compliance is distensibility and the ease of lung expansion, while elastic recoil, or the lung elasticity, is basically collapsibility of the lung. So if surface tension wants the lung collapsed, and if surfactant decreases surface tension, then it decreases lung collapsibility or lung elastic recoil. And lung extensibility and expansibility will increase. We should know also that surfactant synthesis begins approximately at 20 weeks gestation. And do you remember which period of lung development is the 20 weeks gestation in? I hope you are telling me that this is the canalicular period. Yes, so the canalicular period is the period when surfactant synthesis starts, and it reaches the adult levels around 35 weeks gestation. This particular information has a great clinical implication. Specifically, if the baby is born preterm, specifically at less than 37 weeks gestation, and even more at less than 35 weeks gestation, surfactant will not be at its maximal value, and the neonate will likely develop the lung condition that we will talk about today. And this lung condition is NRDS, Neonatal Respiratory Distress Syndrome. But before we move on to NRDS, let's also briefly mention alveolar macrophages, because their function is not that complicated, and we definitely deserve a little bit of mental break after talking about the collapsing pressure, distending pressure, surface tension, and things like this. Alveolar macrophages do the same thing that macrophages do in any other organ system. They phagocytose the foreign material and the microbes, and at the same time, alveolar macrophages release the cytokines and the proteases, which are necessary for the inflammatory process to proceed inside the lungs. Therefore, you can imagine that alveolar macrophages have a significant role in the formation of pneumonia, which is inflammation and infection of the lung tissue. There is one more clinical correlation about the alveolar macrophages which I would like to share with you. Alveolar macrophages, just like the macrophages of reticuloendothelial system, can phagocytose RBCs. Now, when will the alveolar macrophages be able to come into contact with the RBCs? This happens when the hydrostatic pressure inside the pulmonary capillaries increases to such a great extent that these pulmonary capillaries get damaged and RBCs finally extravasate or go out of the blood vessels and into the alveolar lumen, where they are phagocytosed by the alveolar macrophages. And we know that RBCs contain hemoglobin, and hemoglobin contains iron. So this iron, which was initially found in the RBCs, now stays in the macrophages in the form of hemosiderin. And we call such macrophages hemosiderin-laden macrophages because they are loaded with tons of hemosiderin, and on the histologic staining they will look like they have the brown granules inside their cytoplasms. When can we have the hemosiderin-laden macrophages? Well, let's imagine that the patient has congestive heart failure. Specifically, we're talking about left-sided heart failure in this case. When the patient has left-sided heart failure, then the blood backs up from the left ventricle into the left atrium, then into the pulmonary veins, and finally into the pulmonary capillaries. And the blood backing up into the pulmonary capillaries creates enough hydrostatic pressure to cause the microtraumas in the vessel wall and to cause the RBC extravasation. So left-sided heart failure is one of several conditions where we can see hemosiderin-laden macrophages inside the lungs. And in case of left-sided heart failure, these hemosiderin-laden macrophages are specifically called heart failure cells. Let's imagine a second scenario, which has the same pathophysiology. When the patient has mitral stenosis, the blood backs up into the left atrium, then into the pulmonary veins, and finally into the pulmonary capillaries. And then everything is the same that we already discussed in the context of left heart failure. The blood, specifically RBCs, extravasate into the alveolar lumen, and they are phagocytosed by the macrophages, and finally macrophages become the hemosiderin-laden macrophages. So this was the discussion of several types of the respiratory tract cells. Now we will talk about the last topic of our today's episode, which is neonatal respiratory distress syndrome. And this topic is unequivocally the most important and the highest yield topic that we have discussed today. So let's start. What causes neonatal respiratory distress syndrome? To say it very simply, NRDS is surfactant deficiency. And if we recall our extensive discussion about the role of surfactant, then we can imagine the pathophysiology and the symptoms and signs of the NRDS before we basically say it. If the patient, in this case neonate, does not have enough surfactant, then surface tension will be very high because the normal function of surfactant is to decrease the surface tension. And do you remember what surface tension is? Yeah, I know you remember. Surface tension is collapsing force created by the alveolar walls, which tries to collapse the alveoli. So if surface tension is high, then collapsing pressure is high, so the alveoli start to collapse. And then they have extremely hard time to reopen again. If the alveoli are collapsed, there is no gas exchange in that alveoli, right? Because the air cannot reach inside the alveolus. If the gas exchange does not happen, then the neonate with NRDS does not receive enough oxygen. So, on the arterial blood gas analysis of the neonate with NRDS, we will see hypoxemia, which is decreased arterial pressure of the oxygen. And decreased PaO2 will also cause decreased saturation of hemoglobin with oxygen. And hypoxia itself has two complications in the NRDS patients. This is PDA, standing for patent ductus arteriosus, and necrotizing enterocolitis. Let's start with PDA, patent ductus arteriosus. We will not have extensive conversation about PDA here because this is the topic of cardiac embryology, and we will discuss PDA in a great detail in cardiac embryology videos. But let's briefly overview this condition. Normally, when the fetus is in the uterus, he or she has ductus arteriosus, which is the shunt between the left pulmonary artery and aortic isthmus. And this shunt is necessary because during the fetal period of the human development, pulmonary vascular resistance is really, really high due to small diameter of the pulmonary vessels, and therefore we need the shunt which will direct the blood flow from the pulmonary artery into the aorta. But normally, when the fetus is born, increasing oxygen content of the blood closes the ductus arteriosus, because when sufficiently oxygenated blood goes through the ductus arteriosus, this oxygen diffuses into the smooth muscle around the ductus arteriosus, and then oxygen definitely gives us the ATP through the electron transport chain, and ATP causes contraction of the smooth muscle around the ductus arteriosus, which will finally close the ductus arteriosus. Now let's imagine that we have a neonate with NRDS. We already mentioned that this neonate will have hypoxia. Therefore, the smooth muscle cells around the ductus arteriosus are not getting enough oxygen and therefore ATP to contract and to close the ductus arteriosus. This is exactly why NRDS patients will have patent ductus arteriosus, or PDA. Now, as for the necrotizing enterocolitis, the mechanism here is much easier. The GI tract does not receive enough oxygen, and then the intestinal wall undergoes gangrenous necrosis. So necrotizing enterocolitis is truly an emergency, and it needs immediate intervention. Now let's talk about the treatment of NRDS. And first of all, we should try to define how we treat the mother who is about to deliver the neonate with possible NRDS, and then how do we treat the neonate herself or himself. If we have the pregnant female who is about to deliver the baby, and if we consider that this baby will likely have NRDS, we should start giving betamethasone, which is corticosteroids. And that takes me back to the risk factors of NRDS and the pathophysiology behind the corticosteroids and surfactant. Well, the risk factors for NRDS are prematurity, maternal diabetes, and also C-section delivery. There are more risk factors, but these three are extremely, extremely important. And let's talk about each of them. We said that surfactant synthesis starts at 20 weeks gestation, and it achieves the adult levels only at 35 weeks gestation. So if baby is born preterm, let's say the baby is born at 32 weeks gestation, 30 weeks gestation, in that case, there will be insufficient surfactant, which certainly might cause NRDS. Now, as for the maternal diabetes, when mother, or I should say pregnant female, has diabetes and hyperglycemia due to diabetes, the glucose from the maternal blood crosses placenta and goes into the fetus. We receive fetal hyperglycemia, but fetus also has a healthy pancreas, and healthy pancreas produces more insulin in response to more glucose. Idea is that insulin inhibits the release of cortisol, while cortisol is a stimulating factor for surfactant production. In other words, cortisol stimulates surfactant production, while insulin indirectly inhibits surfactant production by decreasing cortisol secretion. So if the infant has hyperinsulinemia due to maternal diabetes-induced hyperglycemia, then the infant will likely have smaller amount of cortisol and NRDS. When we talk about the C-section or cesarean delivery, the idea here is that cesarean delivery is sort of easier for the fetus itself, because if we compare cesarean delivery to the vaginal birth, in order to be born vaginally, the baby should go through this compression by the cervix and the vaginal walls, and the compression is a great physiologic stress which secretes cortisol, right? And if vaginal birth results in cortisol surge, then it definitely results in more surfactant production compared to the C-section, which is less stressful for the infant, and therefore C-section causes less increase in the cortisol levels during the process of delivery. Okay, now let's get back to the treatment. We already mentioned that if pregnant female has a risk factor to deliver the neonate with NRDS, we should start administering the corticosteroids, for example, betamethasone. Now, what happens if the female still delivers the neonate with NRDS, and now we have to treat the neonate herself or himself? In that case, we should supplement the surfactant. We don't have to use corticosteroid anymore, because what is deficient in this neonate is surfactant. So let's give surfactant. And we can give this surfactant through the tracheal tube. Certainly, we should also administer oxygen to the NRDS patients because, as we mentioned in the beginning of our discussion of this topic, NRDS patients have hypoxia, and they definitely get the oxygen therapy. But this creates another clinical point about the NRDS. Since NRDS patients need prolonged oxygen therapy most of the times, prolonged exposure to the oxygen might cause abnormalities in several organ systems. Let's start with the lungs, because oxygen is delivered first to the lungs, right? Oxygen, even oxygen, which usually is beneficial to all the tissues and all the cells, can be dangerous and harmful when it's in excess. What I mean here is that oxygen, when it's excessive, can produce free radicals, oxygen radicals, which then damage the tissues and they damage the cells by lipid peroxidation of the plasma membrane, by oxidation of the cytosolic proteins, and by breakage of the chromosomes. And after these molecular and cellular alterations, the excessive oxygen exposure or oxygen toxicity can cause a condition called Bronchopulmonary Dysplasia in the lungs. BPD, or Bronchopulmonary Dysplasia, is almost like an interstitial lung disease caused by oxygen toxicity. It causes fibrosis, both interstitial and also parenchymal fibrosis of the lungs. Another complication of prolonged oxygen therapy in case of NRDS is retinopathy of prematurity. Excessive oxygen delivered to the retinal capillaries causes damage to the capillary walls, and therefore the retina starts to make even more vessels to compensate for those abnormal vessels already damaged by the oxygen. And when we have all of these vessels, then we get the process called neovascularization of the retina, when there is a very thick layer of the newly formed vessels on the retina. And it definitely decreases the vision, and it's a risk factor for permanent blindness. The third complication of prolonged oxygen exposure in case of NRDS is a condition called intraventricular hemorrhage. Let's go briefly into neuroscience and remind ourselves of the concept of germinal matrix. Germinal matrix is part of the brain immediately under the lateral brain ventricles, which is very, very rich in the blood vessels, especially in the fetal period and the neonatal period of the human development. And when the excessive oxygen delivered by mask or the tube is delivered to the blood vessels of the germinal matrix, these blood vessels also get damaged by the free radicals produced by the oxygen. And when the blood vessels damage, they rupture, and we have bleeding inside the lateral ventricles. And this is called intraventricular hemorrhage. In that case, we will see that a neonate will have altered mental status. For example, neonate might have more sleepiness, and she or he might even have the seizures due to compression of the brain parenchyma. We might also have hypotension on the vital signs, because that blood goes into the lateral ventricles, and the total blood volume of the neonates is not that much. So even a small amount of blood lost inside the cerebral ventricles can cause significant derangement in the vital signs. And if you see the scenario where neonate is extremely, extremely premature, and suddenly they start having seizure or they start having hypotension, please think about intraventricular hemorrhage as one of your differential diagnosis. I'm not saying that this type of presentation is intraventricular hemorrhage in 100% of cases. That's not true. But intraventricular hemorrhage should be in your differential. Okay, finally, we should talk about the screening tests for the fetal lung maturity, which tells us what is the risk of the neonate to have NRDS. There are several of these screening tests, but the most important of them is something called lecithin sphingomyelin ratio, or in short, ALS ratio. As we already mentioned while talking about the surfactant, lecithin is the same as phosphatidylcholine, and this is a specific type of phospholipid. And we said that it is an essential part of surfactant. So the higher the ALS ratio is, the more surfactant we have, because the lecithin is the main contributor to the substance of surfactant. And specifically, we should know that if ALS ratio is at least 2, in other words, if lecithin is at least 2 times more abundant than sphingomyelin inside the amniotic fluid, then fetal lungs are likely mature and the risk of NRDS is really low. However, if the ALS ratio is between 1 and 2, in that case, fetal lungs have transitional maturity, which means that they are not completely immature, but they also are not completely mature. Therefore, there is an intermediate risk of NRDS. However, if ALS ratio is less than 1, which means that sphingomyelin is more abundant in the amniotic fluid than the lecithin, It means that the fetus does not have enough surfactant, and she or he will very, very likely develop NRDS. There are two more screening tests, but they are less important. These are surfactant to albumin ratio, which simply measures the proportion of surfactant and the albumin inside the amniotic fluid. And you can imagine that the higher surfactant albumin ratio is, the smaller the chance of NRDS, because higher ratio means that surfactant is in high concentration in the amniotic fluid. And the second test is foam stability index, which has a very complicated chemical background, and it's really not worth our attention here. We have discussed all of the topics for today, and now let's summarize everything that we talked about. The main take-home points of our today's episodes are: there are 5 stages of lung development, and we should know the clinical correlations and the processes happening in each of these stages. However, the exact time range of the stages is not that important. From the congenital lung malformations, the pulmonary hypoplasia and its causes are the highest yield. When it comes to the club cells, we should remember 3 functions of the club cells, which are degradation of the toxins, secretion of the surfactant component, and club cells being the reserve cells for type 1 and type 2 pneumocytes, and also the other types of respiratory epithelium. From the alveolar cell types, we should certainly keep in mind the functions of type 1 and type 2 pneumocytes and the concepts of surface tension, collapsing pressure, and distending pressure. When we talk about the alveolar macrophages, we should remind ourselves the conditions in which we will see hemosiderin-laden macrophages. And finally, when it comes to neonatal respiratory distress syndrome or NRDS, we should know pathophysiology, risk factors, complications of hypoxia and hyperoxia, treatment, and the screening tests. Practically everything here. So you can leave the voice message on this episode to tell us how we can improve this podcast for you. So thank you for your kind attention, USMLEers, and see you on the next episode.